Welcome everyone. In my presentation I would like to introduce our two projects of our research. My name is Kinga Kovács and currently I'm a pediatric resident at the Department of Obstetrics and Gynecology at Semmelweis University. Our vision is that the focus in neonatal care should be on eliminating as many complications of prematurity as possible. That's why our vision is to investigate neonatal risk factors. To achieve these aims, here are our specific goals. One is related to the histopathology of the placenta and the umbilical cord, and the other one is related to the apnea of prematurity. Our first project is a systematic review and a meta-analysis investigating the role of fetal inflammatory response. A little explanation to this term. Maternal inflammatory response means the inflammation of the maternal part of the placenta, the chorionic membranes, causing chorioamnitis. Meanwhile, fetal inflammatory response means the inflammation of the fetal side of the placenta, and that's the chorionic vessels and the umbilical cord. And to our current knowledge, inflammation spreads from chorioamnitis through the chorionic vessels, causing chorionic vasculitis, to the umbilical cord known as phenicitis. Intrauterine inflammation is one of the leading causes of preterm deliveries, and several studies has already showed the association between chorioamnitis and different adverse outcomes of neonates. However, the role of fetal inflammatory response in this equation is unclear. So that's why our aim is to investigate the role of additional fetal inflammatory response with chorioamnitis. Here is our PECO. Our population contains preterm neonates or very low birth weight neonates, and the exposure group is defined as neonates with chorioamnitis and fetal inflammatory response as well. And our comparison group contains neonates with chorioamnitis alone, and we analyzed several outcomes. The search was conducted in these 4 databases, and at the end of the selection process we had the pool of 22 eligible articles. Here is a list of our outcomes. These are the major morbidities of prematurity. I would like to start with mortality. As you can see, according to these 9 articles that I included in the plot, there is no difference between the odds of mortality between the two groups, between the exposure and the comparison group. The heterogeneity is quite high, and that can be due to the different gestational ages and different population sizes in the groups. And this applies for the further plots as well. Respiratory distress syndrome is a respiratory failure caused mainly by the lack of surfactant in the premature lungs. And here we can see similar distribution with greater heterogeneity. And according to this, we can say there is no association between respiratory distress syndrome and fetal inflammatory response. Early onset sepsis is defined as sepsis occurring within the first 72 hours of life in neonates. And although the result is not significant, we can see a tendency toward the right direction from the zero effect. And the pooled odds ratio is 1.62, which means that the odds of early onset sepsis is 62% higher in the group of neonates with fetal inflammatory response. And that's quite reasonable because early onset sepsis is considered to be transmitted vertically. Late onset sepsis is a quite frequent condition in the neonatal intensive care units and with a high mortality rate. And in this case, we can see a similar tendency as with late onset sepsis. Necrotizing enterocolitis is one of the most frequent gastrointestinal emergencies among preterm neonates. And here we can see a different tendency toward the group of neonates with chorioamnitis alone. Our next outcome is bronchopulmonary dysplasia, which is another respiratory morbidity and is defined as requirement of supplemental oxygen at the 36th weeks of postmenstrual age. And here we can see a tendency towards the neonates with fetal inflammatory response group. And here we would like to make a subgroup analysis as well. All in all, the strength of our study that we set quite strict rules regarding histological classification, and we analyzed several outcomes. And where it is possible, as I mentioned at BPD, subgroup analysis will be performed. Just as important are limitations. In certain articles, the outcomes are based on slightly different criteria. And these outcomes are multifactorial diseases, so they are highly influenced by different factors, such as gestational age or mortality. Our implication for practice is that regular histological examination of the umbilical cord should be considered, and fetal inflammatory response can be part of the sepsis assessment. Our implication for research is that beside chorioamnitis, fetal inflammatory response can be part of the basic characteristic as well. Our second project is a protocol of a randomized control trial, the effect of additional pre-extubational loading dose of caffeine citrate. One of the most common indications for intubation or reintubation are frequent episodes of apneas. And since the CAP trial, which is a caffeine for apnea prematurity trial, there is an evidence that caffeine can decrease continued apnea and associated with shortened duration of ventilation. Clinicians prefer to use non-invasive ventilation initially to avoid mechanical ventilation. However, there are cases when it's inevitable, and in those cases they try to remove this endotracheal tube as soon as possible, because its complications such as bronchopulmonary dysplasia and its long-term sequelae like asthma or reduced lung function. That's why our aim is to investigate of a higher level of caffeine in this quite vulnerable period of the neonates, in the peri-extubational period. Our clinical question is, does additional loading dose of caffeine citrate 1 hour before planned extubation reduces the extubation failure? We will include neonates born before the 32nd gestational week is completed and had been mechanically ventilated for at least 48 hours. Our intervention will be an additional dose of caffeine citrate 1 hour before planned extubation, and the control group will receive the routine dosing regimes. Our primary outcome is reintubation within the next 48 hours. The implication of this research can be that caffeine can decrease extubation failure, mechanical ventilation days, and thus BPD. And this study can contribute to finding the optimal dosing regimes. Here you can see our eligibility criteria, both inclusion and exclusion criteria. It is planned to be a 2-arm study with the intervention of 20 milligram per kilogram loading dose of caffeine citrate 1 hour before planned extubation. Beside our primary outcome, we have secondary outcomes as well, such as frequency of apneas, heart rate, gastric residuals, and blood pressure. Here is a quick overview of our 2 projects and the planned submission dates. And I brought a quote for the tiny ones: "From a tiny spark may burst a mighty flame." Thank you for your attention.
I would like to ask about the first part of the presentation. And you said that fetal inflammatory response syndrome and chorioamnionitis are evaluated. And did you think about the different levels and stages of the disease? So the different severity, was it included, or are you planning a subgroup analysis on that?
There are stages of chorioamnitis and fetal inflammatory response as well, but it's very rare that they are reporting on that. Actually, from this 22 article, there are 2 which included the stages as well. So I think we cannot do subgroup analysis on it, but it's a really good comment, because it would be really nice that we could do that.
My question is regarding to your first project. You mentioned that the outcomes are based on slightly different criteria. What do you mean by it?
This problem was different with different outcomes. For example, with mortality, I pulled those mortality parameters when they mentioned either it's neonatal mortality or mortality before the 36 weeks of postmenstrual age or mortality before discharge, because this can be merged because they have similar time period. But there are follow-up studies which I had to omit it because they reported mortality at 2 years. It was different. And for example, in case of sepsis, both early and late onset sepsis, I met this problem that they reported it with a specific time frame, like they will use these 72 hours, but they had the different definition for sepsis itself. Like I think most of the study defines sepsis as clinical symptoms and elevated laboratory parameters, and there are a few. For example, here we can see the last one. They are defined sepsis as positive blood culture.
In case of necrotizing enterocolitis, there were more different tendencies than in other outcomes. Do you have any explanation for them?
Yes, we saw different tendency in case of necrotizing enterocolitis, and that can be caused because they are observational study on one hand. On the other hand, necrotizing enterocolitis is a highly multifactorial disease. So, and these are studies from different institutions with most probably different feeding protocols as well. And necrotizing enterocolitis is highly depending on the local feeding protocols. And the other thing they all reported as necrotizing enterocolitis from stage 2 according to Bell's criteria, which is quite mild form of necrotizing enterocolitis, and it gives a definition of clinical symptoms and unspecific radiological signs, so that can cause quite diverse distribution.
I would like to ask a question concerning that you have mentioned that you will check for the intubation in the first 24 hours. So do you have an estimate of what proportion of the reintubation happens in the first 24 hours? And do you plan to collect data about those reintubations that happens later than that?
You mean 48 hours?
48, sorry.
Yeah.
My bad.
According to the literature, almost 70% of the reintubations, because of respiratory reasons, because that's an important factor, happens within the next 48 hours. And according to our experiences in our unit, we had 80% of reintubation happening before 48 hours. And yes, I think we would like to collect those data as well about reintubation later in time.